All right, let's dive into two of the most critical and honestly most confused diabetic emergencies, DKA and HHS. The NCLEX absolutely loves to test the subtle differences between them. And look, knowing this stuff isn't just about passing an exam, it's about saving lives. So by the end of this explainer, I promise you're going to be able to tell them apart with total confidence. So let's paint a picture. You've got two patients come in. One is younger, maybe a teenager, and they're doubled over with severe abdominal pain. Your other patient is older and they're just confused, not making sense. The one thing they have in common, dangerously high blood sugar. Now, knowing what's really going on with each of them, well, that's not just some textbook trivia. It is absolutely critical for giving the right care and for crushing that exam question. So, here's our game plan. First, we'll look at the typical patient profiles for DKA versus HHS. Then we'll get into the nitty-gritty of why they're so different. It's all about ketones versus dehydration. After that, we'll break down the specific lab values and clues you've got to know. And we'll wrap it all up with the most important part, what you need to do first as the nurse. Okay, let's start with the who. Seriously, the patient's background is often your very first clue on an NCLEX question. Here's a little memory trick for you, and trust me, you won't forget it. DKA is the classic emergency for type 1 diabetics. HHS, that's almost always our type 2 folks. Just think about it alphabetically. D comes before H in the alphabet, just like type 1 diabetes comes before type 2. Easy, right? And the other big tell is the onset. DKA is fast and furious. We're talking hours to a day. HHS is more of a slow burn, kind of creeping up over days or even weeks. So what's the real fundamental difference that sends these two conditions down completely separate paths? It all comes down to one little thing: insulin. Or, the lack of it. Let's break down exactly how this one hormone changes the entire story. In our type 1 diabetic patient, there is an absolute total lack of insulin. 0. Without insulin, glucose can't get into the cells to be used for energy. So you've got this bizarre situation where the cells are literally starving in a sea of sugar. The body panics. It thinks it's starving, so it flips this emergency switch and starts burning fat for fuel. Think of it like a diesel engine. It's a backup, sure, but it produces this dirty, acidic exhaust. And that exhaust? Those are ketones. And this right here shows you that chain reaction perfectly. It's a straight line. No insulin leads to the body burning fat. Burning fat creates ketones. Ketones are acids. And as those acids pile up in the blood, the body's pH plummets, and boom, you're in metabolic acidosis. It's a direct, totally predictable cascade. Now let's switch gears to HHS. This is where it gets really interesting. See, in type 2 diabetes, the body is still making a little bit of insulin. It's not nearly enough to keep blood sugar in check, but it's just enough to stop the body from freaking out and burning fat. So no fat burning means no ketones, and no ketones means no acidosis. But here's the catch. That blood sugar just keeps climbing and climbing and climbing. The blood literally turns into this thick, sugary syrup, and the kidneys go into overdrive trying to flush it all out, which leads to massive, life-threatening dehydration. Okay, so now we get the why. Let's get into the what. For the NCLEX, you absolutely have to recognize the signs, symptoms, and lab values that just scream DKA or HHS. This is where the points are, people. This slide right here, this is your NCLEX cheat sheet. Look at the glucose levels. In DKA, yeah, it's high, over 250, but in HHS, it's just astronomical. We're talking over 600 easily. The key difference maker, though, is the ketones and acidosis you see in DKA, which are totally absent in HHS. That acidosis is what drives those classic DKA symptoms, the abdominal pain, that fruity breath, and Kussmaul breathing. That's that super deep, rapid breathing where the body is desperately trying to blow off all that acid. In HHS, the story is all about that profound dehydration, which leads to severe neurological changes, like confusion and even a coma. And to really lock this in, just remember the mnemonic DKA. D is for dehydration, because they are dry. K is for ketones and Kussmaul respirations, that fruity breath and deep, fast breathing. And A is for abdominal pain and acidosis. So if an NCLEX question gives you a young diabetic with belly pain and a pH less than 7.35, ding, 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 it's DKA. For HHS, the mnemonic is just as simple. Think triple H. Higher glucose, way higher, like over 600. Higher dehydration, we're talking extreme. And head changes, those are your key neurological symptoms. If you get a question about an older diabetic patient who's confused and has a blood sugar of, say, 800, your brain should instantly jump to HHS. Okay, you've nailed it. You've figured out the problem. Now for the most important part. What do you do first? The NCLEX is all about prioritization. And believe me, knowing the correct order of your actions here is beyond critical. And here it is, the #1 rule you have to burn into your brain. For both DKA and HHS, the first thing you do is fluids. I'm going to say that again, fluids before insulin, always. You have to rehydrate that patient, fill up their tank, and stabilize their fluid volume before you can safely even think about touching that high blood sugar. So here's your step-by-step plan. Step 1, hydration. We're hanging bags of 0.9% normal saline. Step 2, stabilize the sugar. We start an IV drip of regular insulin to bring that glucose down nice and slow. Why slowly? Because if you drop it too fast, you can cause dangerous fluid shifts in the brain, leading to cerebral edema. So slow and steady wins the race. And step 3, add potassium. As that insulin starts working, it shoves potassium out of the blood and into the cells. This can cause a massive drop in their blood potassium levels, which is super dangerous for the heart. So we always give potassium with the insulin to prevent hypokalemia. All right, let's wrap up with some rapid-fire NCLEX tips you can't forget. Number 1, only regular insulin can go in an IV. Got it? 2, you must do hourly blood sugar checks for any patient on an insulin drip. No exceptions. 3, remember sick day rules. Stress from being sick raises blood sugar, so patients have to keep taking their insulin, even if they're not eating. 4, the #1 trigger for both DKA and HHS is an infection or illness. And 5, keep your eyes glued to that EKG. Potassium imbalances show up fast on the cardiac monitor. And that brings us to our final thought. Look, fixing the high blood sugar is just the beginning. The real art of nursing is playing detective and figuring out why this happened in the first place. Was it an infection? Did they stop taking their meds? Was it stress? Answering that question, well, that's how we actually prevent this from ever happening again. So what do you think is the biggest trigger that gets missed in the real world?